Hi, everyone, and welcome to the American Ambulance EMS podcast. I'm Dr. Danielle Campaign, American Ambulance's Medical Director. I'm here with our fantastic co-hosts, Dr. Patil Armenian and Dr. Sajin Bhakta.
Hi, everyone.
Hello.
And today we have amazing guest, Mr. John Gage, one of our fantastic paramedics.
Hello.
And today we're going to be talking about airway management. So John, thank you for being here today. Please tell us about yourself, how you got into paramedicine and how this became a profession for you.
Well, actually, I just kind of fell into it. I graduated from high school and was taking some classes at City College, and I had no idea what I wanted to do with my life. I was doing ski patrol at the time. Naturally, like EMT kind of fell into the mix, and so I came for a ride along at American Ambulance, and I did the EMT program through American, and then did 6 months and went to medic school, and was sponsored by American Ambulance. Just really haven't looked back since. I was a medic for a few years, and then I got hired on with Skylife. I was with Skylife for about between 5 and 6 years, and had a lot of really incredible experiences and learned quite a bit. Then left, came back here about a little over a year ago, and the CCT position opened up, so I interviewed for it. So now I'm going through the pipeline to go for the CCT certificate. And
for those listening outside the system, CCT is our critical care transport team. And so I do a lot of interfacility transports and I have a lot of drips and ventilator management. So we're excited to have you on the CCT team.
Well, thank you. I'm excited to be a part of it.
So as we're talking about airways, and you've had a lot of airway experience, whether you're intubating on the helicopter with Skylife or you're using eye gels or intubating in the field. Can you share one of those cases with us or one that sticks in mind, either a really difficult one or a really easy one? Or
Yeah, we responded to it choking, and the patient was elderly and severe dementia, dysphagia, multiple CVAs, had the standard laundry list of past medical history. And they gave him a peanut butter and jelly sandwich, and he inevitably choked on it, ended up going into cardiac arrest. And we arrive on scene and we're managing this patient, and he has an occluded airway, utilizing suction as much as we could. But I don't know if anybody's ever tried to suction up peanut butter.
It's very gooey.
It's near impossible. So the only thing we really had were the McGill forceps. And so it was just little scoops at a time, trying to clear enough of the peanut butter out and the jelly and bread and whatever else happened to be in his airway, enough to be able to visualize the vocal cords. You know, it took longer than any, medical professional would want it to last. But I was finally able to clear enough out, visualize the vocal cords, pass the tube through, successfully intubated them, and we did end up transporting and, ran through our ACLS algorithms and stuff.
And were you doing the laryngoscopy and the removal of all that peanut butter? Was that on the ground or on a table? Or how'd you set the patient up?
That was on the ground. We laid the patient on the ground. I was on my belly.
Do you have any advice for someone who hopefully never has to come across this same situation, but
Planning. I think planning is the key. Ideally, you have a BLS airway already in place. The patient is being bagged with a BVM. You have end tidal on the patient. You have suction on, ready to go at the head. So you don't have to look for it. You just reach and you grab for it, and there it is. Setting up laryngoscope blades, kind of anticipating, judging by the size of the patient, whether they have an anterior airway, am I going to use a Miller or a Mac blade, what size, and determining, which ET tube size I'm going to choose, and also pulling out a size above and below, making sure I have my syringe ready, I have my securing device, whether it's going to be a Thomas lock or if it's going to be tape. On the helicopter, we had access to bougies in case we're not able to visualize or we're not able to, pass the tube.
Was the bougie your backup airway, or did you ever use bougie as the first line attempt?
The bougie was typically backup. Ideally, we tried to go in and just visualize the balloon, the tube passing through the cords. So once I have all my equipment set up, there's also a lot of communication between you and your partner, especially on Skylife. The nurse is the one that's going to be pushing the RSI medications, communicating with them like, I have all of my stuff. It's ready to go. I'm ready for you to push the medications. The nurse will verbalize, hey, I'm ready to push the medications. Do you have your stuff? You have your equipment ready to go. That way you're not pushing medications and then the person that's actually doing the intubation is scrambling around in a helicopter trying to look for stuff. It's at night and there's flashing lights and vibrations, and, there's just a lot of potential for things to go wrong. So communication, and, once you have all of your equipment ready to go and the nurse is ready to go with their medications, they push the medications. And it usually took about, 60 to 90 seconds or so for the medications to start kicking in. Continuing to bag the patient, checking the jaw, for the paralytic to kick in. And then, when you're ready to intubate, you remove, if you have an oral airway or a nasal airway, you remove them, and you insert the laryngoscope blade. Visualize whether you're using a Miller or a Mac. Getting it into the vallecula or lifting up the epiglottis, visualizing the vocal cords, and visualizing the tube going through the cords. And then once you put the tube through the cords, your life is holding on to that tube. And your only job is to keep that tube in that place until it's secured. You inflate the balloon, you remove your stylet, attach your Thomas lock or your securing device, attach your end tidal. We used end tidal as a gold standard for proper placement, alongside visualizing the tube going through the cords.
Can you think of something that's different between a mannequin and a real life person when you're doing an intubation?
Mannequins are, they're stiff. The high dollar ones, they can make more human, more anatomical. They can kind of get a little close. The ones that you guys have at UCSF in your training lab is probably the closest thing to a human as far as mannequins that I've ever experienced. Patients, they're awkward, they're heavy, especially when they're paralyzed. If you have them in a position to where, all right, I'm in a good position where I can intubate this patient. In that sense, they're easier to manipulate. With mannequins, they're usually set up anatomically correct. And so you don't typically get like an anterior airway or a posterior airway, or like deformities, or, somebody that has throat cancer or has a stoma, all those other kind of outliers that we come across occasionally out in the field or in the hospital. So I would say they're easier to manipulate and maneuver. They're definitely easier as far as lifting the jaw up. You get those mannequins and they're hard plastic rubber that's been in a closet for 6 months, and they don't smell like Pam cooking spray. Or at least not typically.
So true. Well, thank you for coming today, for sharing your story and sharing your approach to airways. We really appreciate it.
Oh, no problem. Thank you for having me.
All right, so let's talk about airways, and let's go into, let's talk about different airway devices. Saad, do you want to kick us off?
Sure. So first, just very basically, what are we using airway devices for, and what do they do? So an airway device should help facilitate passage of air or oxygen from the environment to the patient's lungs. And we want to remove or bypass any obstacles a person may have from getting that air movement between the environment and the lungs. There are three really main reasons we use advanced airway devices. Number one, the patient is not oxygenating well, and we need to oxygenate the patient better. Number two, the patient's not ventilating or breathing. This usually applies to the patient unable to getting carbon dioxide out of the body. And then number three is airway protection or altered mental status. If the patient has lost their gag reflex and their tongue is flopping back into their throat, they're not able to breathe, and that is another reason we use an advanced airway. And there are a few different types of advanced airways. For a long time, we had used laryngeal mask airway devices. Some common ones are the King airway. We've now moved on to using something called the iGel. And basically, these are devices that you can place in the back of the throat without any significant manipulation, and they should allow you to bag the airway without getting too much air into the stomach.
Yeah, let's talk about the different airways and what we are using here at American and some of the stats, epidemiology around this.
So for American Ambulance's airway stats in 2019, our success rate with endotracheal tube intubations was 75.7%. And with King tubes, the success rate was 90.3%. So much higher success rate with the King tube. And then in 2020, remember, this is when iGels really entered into play. What we see is that the number of attempts actually went down a lot because now we're really using King tubes and iGels. So only 44 attempts at endotracheal intubations in 2020 versus 177 attempts in 2019. So in 2020, the success rate with endotracheal tubes was 66%. With King tubes, it was about 91%. And with the iGel, it was 94%, leading to an overall success rate of about 89% with all of our advanced airways.
And just for a caveat for the numbers, this is not the first pass success rate, but the procedure was documented and it was documented as successful. So for example, if the medic attempted an intubation and then the patient gagged, they pulled the blade out and just bagged the patient, that would be recorded as an attempt, but not successful. So don't assume that all the unsuccessful ones are that the intubation, the tube went into the esophagus or something. That just means an attempt was made and then they did something else. The other thing is just a caveat around March of 2020, the county actually removed intubation as part of the scope because of COVID, and they didn't want paramedics that close to patients' faces, and we went straight to the iGel as the airway of choice. That's probably why you're seeing a lot of the attempts go down in the 2020 stats, because the iGel was kind of the supraglottic airway of choice, the advanced airway of choice during the COVID pandemic.
And the good news is with the iGel, we started approaching the success rates that we want. Our goal is to have a successful airway procedure performed 95% of the time, and the iGel success rate was 94.2%.
And as we'll talk about, the iGel is a very appropriate advanced airway for a lot of circumstances, even and especially in cardiac arrest, which we consider to be one of the most hectic and chaotic procedures and calls that we go to. It really is appropriate to use an iGel, and that's an advanced airway, and that's appropriate.
And one thing to talk about, since we don't do rapid sequence intubation, that you're doing when you're going to intubate somebody or put in an airway, you really got to do a pre-airway assessment. Like, can this person tolerate a supraglottic airway, or can they tolerate an intubation? Because we don't have any meds to paralyze them. So things I like to recommend is the jaw loose? Like, is that jaw not clenched? If that jaw is clenched, there's no way you're going to get a blade in. And then will the patient tolerate an OPA? Can you put an oropharyngeal airway in, and will they not gag on that? And then if the patient has a loose jaw and tolerates the OPA, then you can proceed with your advanced airway, whether that's an iGel or an intubation.
Here we work in the Central California EMS agency, where RSI is not a part of our protocols, but those of you listening may be working in areas where you do perform RSI, in which case you have medications available to you to paralyze that patient and intubate them if you have to.
And let's jump to, how are we going to optimize our airway? What are things we can do to make this procedure, this airway, more successful?
The most important thing you can do is prepare ahead of time. Prepare mentally, prepare physically, get your equipment and your mindset ready for this procedure that is pretty rare, but can be life-saving. So always know what equipment you need ahead of time, know where it is in your bag or your ambulance, and always have a few things ready. Those few things are an oxygen source. Make sure you can pre-oxygenate the patient. It's always really important to try and perform your intubation with the nasal cannula still in place and delivering oxygen. That's called apneic oxygenation. And that can help keep their oxygen saturation up even when you're performing your intubation. Positioning the patient properly, as we'll talk about, is really important. Ramping the head or getting them in the sniffing position is really important to optimize your view and your chance of success. And then always have suction ready. These calls that you'll go to will have fluid or emesis or foreign bodies in the airway, and it's really helpful to have suction.
Another thing to do is you can assess, as you walk up to the patient, and I really recommend every paramedic EMT, as you talk to patients, look at them and go, would you be an easy airway or you be a difficult airway? You know, you don't even need to deal with their airway. It's good practice in your mind to making quick assessments about, is this going to be a hard airway? So things that can predict difficult airways, it could be a stiff neck, right? Do they have a C-collar on because maybe they broke their neck or had a fusion done 2 weeks ago? Are they elderly and have rheumatoid arthritis and are kind of hunched over? We've all seen those little grandmas walking down the street that are really hunched, like that stiff neck. Do they have a lot of facial hair? Do they have like the Santa Claus beard, or do they have like just a lot of facial hair? So you thought, gosh, that's going to be hard to bag that person. Are they actively vomiting? And so you can say like, oh, this is going to be a difficult airway because there's already vomitus in the airway. What am I missing, guys? What else do you assess on your difficult airways?
I guess if they're a trauma patient and you can't really move around their neck too much, that's one I think about.
I'm thinking like dysmorphic features sometimes, or like people have braces, or, we have a methamphetamine problem in Fresno. So there's a lot of what we would call meth teeth, right? So you have some jagged or some teeth. So you think like that's going to be a hard airway because you worry about bumping those teeth or those teeth falling out. So let's jump to like, when should you go for an iGel versus an ET tube? Has this been looked at in the literature?
Well, the good news is yes, it has been looked at. And there was a pretty big trial called the Airway 2 trial published in JAMA in 2018. That's the Journal of American Medical Association, very prestigious journal. And they randomized medics to use iGel versus endotracheal tube for out-of-hospital cardiac arrest in England. So this was a pretty big trial. It was a multi-center cluster randomized trial in 9,296 adult patients who had non-traumatic out-of-hospital cardiac arrest. And 1,523 paramedics were involved in this study. And so they basically looked at the primary outcome of good neurological outcome at 30 days or hospital discharge for patients that either received an iGel or an endotracheal tube. And what they saw was that for these outcomes, no significant difference between the two airway modalities. Each was about 6 to 7% making it to discharge. And successful ventilation on the first try was greater in the supraglottic airway or iGel group, which was at 87.4%, whereas successful ventilation on the first try was only 79% for the endotracheal tube group. So that's a pretty big difference. And then when they looked at complications such as regurgitation or aspiration, there was actually no difference in these complications between groups. So this was a very, I think, well done big study that showed you can use a supraglottic airway such as an iGel instead of an endotracheal tube. And what they actually noticed during the study was those paramedics that were randomized to use endotracheal intubation were less likely to use advanced airway management than paramedics randomized to use the supraglottic airway device. So it's like when people are used to something, if you give them the choice of doing the thing they're always used to, that's what they're going to pick. But those paramedics who had to use the supraglottic airway device and even weren't totally used to it at the time did very well with it.
It is a great testament to why our own agency switched to the iGel. It's very easy to use, requires not very much training before you're comfortable with it. And this study does show that it is no difference between an intubation for out-of-hospital cardiac arrest. And that's great because that's our main goal, is to get these people to survival. Let's talk about airway monitoring tools. Like, what do we have in our bags that they can use to help monitor these airways?
So whenever we're thinking about airway management, we always typically think of oxygen saturation, the O2 sat. And that's really helpful in certain situations. But when we're talking about advanced airways, we also want to think about the end tidal CO2. We want to assess their oxygenation and ventilation, as we mentioned earlier. Both of those can be reasons to pursue advanced airway techniques. So oxygenation happens when oxygen interfaces with the lungs, and we know we all need oxygen into our blood to help our organs function properly. And ventilation is the air movement out of the lungs. Typically, we're thinking about exhaling carbon dioxide, which is what we measure when we measure end tidal CO2. So the gold standard for end tidal CO2 monitoring is waveform capnography, and it represents the amount of carbon dioxide in exhaled air. Typically, there's a graph and then it gives you a number. The number is capnometry, which is the partial pressure of CO2 detected at the end of exhalation. And this is what we call end tidal CO2. So normal numbers for end tidal CO2 are between 35 and 45 millimeters of mercury. And this number can give us a good idea of the patient's respiratory effort. In patients with normal, healthy lungs, the brain responds to changes in CO2 to control ventilation. We can observe this physically without numbers by observing chest rise, respiratory effort, counting the respiratory rate, and listening for breath sounds. Using that end tidal CO2 adds on objective measurement to these findings. The respiratory rate should increase as CO2 rises and decrease as CO2 falls. That would be the patient responding appropriately to changes in CO2. In patients in respiratory distress, they may inhale enough oxygen and have normal pulse ox, but they could still struggle to get air out. These are typically your asthmatics and your COPD patients who really can't exhale very well. And they progress to respiratory failure from fatigue. They're really trying to squeeze all that air out. They're using all of their accessory muscles. The effort that they give will really fatigue them, and they're unable to get rid of all that CO2. That leads to hypercapnia or hypercarbia, and that can cause altered mental status and cause you to be in respiratory failure.
So end tidal CO2 is a pretty good assessment to rate perfusion, especially in codes. So for example, in cardiac arrest, there's no circulation or metabolism. And so there's no CO2 production unless you have effective chest compressions. So it can be like a guide to see if you're performing chest compressions well enough. It gives you, this active feedback, live feedback on quality of your compressions. And an end tidal CO2 of less than 10 really indicates that compressions are not fast or deep enough. So either you improve your compressions or you switch out with somebody else to do chest compressions. And then once your circulation is restored, you get a spike in end tidal CO2. And this happens before a pulse is detected. So I really always think about how an end tidal CO2 is the fastest detection of, a change in your pulse or your oxygen saturation. You kind of look at that first, and that's going to help you. And I think this idea of using it during CPR is really useful.
Yeah, we carry this on the rigs, and so they can hook it up to the iGel, they can hook up to the ET tube, or you can hook up to the bag when you're bagging them. So it really gives you a good assessment of that perfusion. Are you perfusing the patient? The goal would be you're perfusing the patient perfectly while you're doing CPR, right? That we're augmenting their heart enough that they can perfuse.
Exactly.
All right, now that we finish up with end tidal, let's talk about pulse ox. So I know that's kind of a lot of people's go-to monitoring of choice.
So pulse oximetry assesses oxygenation and works by measuring how much of each red blood cell is bound to oxygen. It's expressed as a percent, or an SpO2, and a normal SpO2 is greater than 92%. This measures the direct oxygenation of the blood. It does not assess perfusion or ventilation. Pulse oximetry measures the color of the hemoglobin molecule and then uses math algorithms to estimate the percent of hemoglobin saturation and assess oxygenation. And so really both of these tools together, the capnography and the pulse oximetry, should be able to give you an accurate estimation of how your patient is breathing and if they need advanced airway management.
So Patil, do you want to lead us through like a step-by-step intubation series with tips and pearls?
Of course. So just like John mentioned, preparation is key. And I always say, the more prepared you are, the less bad things are going to happen. Always have either a written or mental checklist and practice it over and over until you feel comfortable. So step 1 is pre-oxygenate. This is really key. So while you're getting everything ready, make sure your patient is on oxygen. Now, the equipment that you're going to want with you is going to be your intubation blade with a light, an ET tube, or your LMA, or your iGel, or your King tube, whatever supraglottic airway you're using in your region. If you're using an endotracheal tube, you're going to want a stylet in that, a syringe to inflate it, suction, possibly a bougie if you're in a system that uses a bougie. So really you just want everything. You want your BVM, obviously, that's probably already going. And then just be cognizant of the environment you're in. So in Fresno, it gets really hot in the summer. And so because of that, people can have really dry mouths. So it might be helpful to use a really small amount of lubricant applied on the cuff of the ET tube so that it can go through the cords easier and go in the mouth easier. The next thing to think about is positioning of the patient. So you want to make sure they're laying flat and that their head is in the sniffing position in a non-trauma patient, so that basically the ear canals line up with the sternal notch. Just think you're trying to open up that airway space. If their chin is kind of like folding towards their chest, you want to make sure you get that chin up and out. And if you can, get them on laying flat on a tabletop or on a gurney or a bed, that might be easier than being on the ground. Of course, sometimes on the ground is what you have to do. Now, so I always feel like when it comes to the next step, the mouth opening, that's really kind of like one of your make it or break it points in my mind, because it's like that's when you're really entering the airway. You kind of scissor your thumb and your middle or index finger to push down on that bottom jaw and then push up on the upper jaw. And you're just trying to crank that mouth open as much as you can. And then just think, you really want to move that patient's upper jaw more towards you and introduce a little bit of neck extension to exaggerate the sniffing position so that you can get a better view.
And this, of course, is in the non-trauma patient. Of course, in the trauma patient, you're not going to be moving the neck. They're going to be in C-spine. But what we're talking about here is in the non-trauma patient. Sorry, continue, Patio.
No, our next step is to insert the laryngoscope. So you're holding at the junction of the handle and the blade so that you can have a firm grip and also fine control over the entire unit. So you don't want to hold too high on the blade and you don't want to get too low on the blade because then your hand will get in the way. So remember your target, visualize it by looking at the exterior of the neck. The blade is going to go in slightly to the right of the tongue. Then you're going to sweep the tongue to the left as you advance the blade in. And you're going to try to keep the end of the handle lower than a 45-degree angle towards the body so that you're not really rocking back. And then just remember to mind the teeth. Use the blade to kind of hug the tongue, and you're just basically going to follow the tongue down to its base, and then you're going to be right in the vallecula. Now, this is assuming that you're using a Mac blade, which is the one that we tend to use the most often. With the Mac blade, you're going to press the blade into the vallecula and just lift up. You should be able to visualize the epiglottis, put the blade in the base of the epiglottis, and then kind of be able to lift up and see the cords. Now, if you're using the Miller blade, then you're actually going to lift the epiglottis itself up. So then the goal is that you're going to see the vocal cords. That's like when you see it, it's like, vocal cords. And then you're basically going to try to insert the tube into the cords. And you are not going to stop looking at those cords at all for anything. Once you see them, keep your eye on the prize, and you're going to put your ET tube straight through the cords, or your bougie. If it's kind of difficult airway, or if you like to use a bougie first, you can put your bougie through the cords. But the bottom line is, until something successfully goes through the cords, you're not going to stop looking at them.
Let's take some pro tips from the group, though. So say I've put my blade into the mouth. I'm looking, I don't see anything. Or maybe I just see tip of epiglottis. I don't see cords. What are some tips?
I think the first thing is, if you see the epiglottis and you aren't able to see past it, try to advance your blade just a little more. Sometimes getting right into that base of the epiglottis or that vallecula space will really lift it up and out of the way. And then there are a few things you can do with your opposite hand, the right hand, to try and maximize the potential for a good view. Put your right hand underneath the patient's head and lift the head up off the ground or the gurney. This, again, just exaggerates that sniffing position and will hopefully align the axes so that your eyes can see the prize.
Now, a lot of people ask about lefts and rights. And just remember, even if you are left-handed, you're always going to keep your Mac blade in your left hand. And if you're right-handed, you're still going to keep it in your left hand. And these blades are not made for handedness. They're always made in that way. If you're a right-hand person, I've seen some people say, well, I'm better with my right. I want to use the Mac in my right. It doesn't work because the way the blade is angled actually hinders your view more. Just remember, for handedness, the blade is always in your left hand and your right hand always has a tube.
The other thing you can try to do with your right hand, if you don't have an assistant, you can have your right hand over the thyroid or the cricoid membrane and put a little bit of pressure posteriorly to try and get any vocal cord or larynx that is very anterior and push it back posteriorly into your view. Now, a little side note on this is called cricoid pressure. It's controversial. It used to be routine in all airway management. We thought that by pressing down on the larynx, you could occlude the esophagus and prevent air from getting down or prevent aspiration. This really hasn't been shown to be the case. So it's not recommended for routine use, but it does help if you have a very anterior airway to try and get it into your view.
Then also, what about rocking back? Like, you really don't want to rock your wrist back. So how do you recommend, Sajjan, the best placement of the wrist?
So I think this is probably one of the biggest things that is always taught as the golden pearl and is so hard to do in real life. You just don't know that you're rocking back with your left hand. The mannequins always have that click function that clicks if you rock back onto the teeth. But really in real life, you're really focused on seeing the chords and you forget that your wrist starts to rock back. So really, all of the lifting motion should be happening from the shoulder or the elbow. Your wrist should stay nice and locked. Your blade should be, at a 45-degree angle away from you. And you really should be lifting in the direction of the handle, right? So that is up and away from you. And keeping that space between the front teeth and your blade and maximizing that space, if you think about that, then that will help you lift as opposed to rocking back to get your view. Rocking back is not only harmful for the patient's teeth and their mouth, but it also blocks your view. If you think about it, you're really just rocking back and occluding your own visualization of the chords. So really, if you're having trouble visualizing the chords, think about lifting up and away from you. Use your shoulders and your elbows and don't use your wrist.
So all fantastic tips. A couple times, multiple people brought up the bougie. So John brought up in his case, we brought it up here. And so right now, the bougie is not part of the intubation procedure in our 4-county EMS system. But lots of other listeners have this tool, and hopefully we will have this tool in our own EMS system soon. So let's talk about some tips with using the bougie.
I think my main thing is just to get used to it, practice with it. You're holding it between your thumb and index finger like a dart. And just one thing that I've really actually noticed in real life is once you take the bougie out of the package, you really do have to bend the tip a little bit more because it comes out really straight. And so you do have to bend it up so that you can then angle it into the right place, just because the airway is a little bit anterior and sometimes a lot anterior. And so even though the little tip has a little angle on it, that's usually not enough. You have to take it out of the package and bend it a little bit.
And then you're doing the bougie work with your right hand while your blade is using the left hand. The other thing I realized with the bougie, a lot of times people put the bougie into the airway and they have their tube preloaded onto it like a stylet. But then they remove the blade and then all the soft tissues fall, right? The tissue falls and they can't get it in. So always remember to keep your blade in, keep that MAC in lifted up. Even if you can't see everything perfectly, your eyes know where it needs to go. And then you're going to guide that tube over it. So keep that blade in to lift the soft tissues up. Sajjan, what else are we missing on the bougie?
So there's actually been studies, and a recent study published in actually March of 2021 in the Annals of Emergency Medicine titled "The Routine Use of a Bougie Improves First Attempt Intubation Success in the Out-of-Hospital Setting." So prospective observational pre and post study design out of Seattle, Washington. Study was used to compare first attempt success during out-of-hospital intubation with direct laryngoscopy for patients intubated 18 months before and then 18 months after a protocol change that directed the use of bougie on the first intubation attempt. So the protocol changed so that it was mandatory to use a bougie after the change. The study had about 800 intubations pre and post the routine use of bougie, and the EMS system showed the first attempt success rate increased from 70% to 77% with bougie use, which was statistically significant. So the study concluded that bougies should be used routinely for all pre-hospital intubations.
And Seattle is an EMS system that uses RSI on the ground units. So just keep that in mind. I think this was a study where these were patients getting RSI.
Correct. But another thing it talks about is kind of like what John mentioned is they had bougie as a backup. And one of the things is if you want to be really comfortable with your backup, so I can kind of see why they're making bougie routine use because then they're excellent. They don't need the backup because they're using it every time.
So the rule of thumb is that you can advance the tube 3 times the size of the tube. So if you're using an 8.0 tube, you may be wanting to advance to 24 centimeters at the teeth. Now, that's fairly deep. Most patients will require about 21 to 24 centimeters at the teeth. The best rule of thumb is to advance the tube until the balloon just passes the cords, maybe about 1 to 2 centimeters past the cords, and then you know that it's in a proper position. And as long as the balloon is past the cords and you inflate it, it should be in the proper position.
And sometimes if you do not remember how far you went in, remember, you can always listen. So you've already put the tube in, you know it's in the cords, but you say, hey, where was that balloon? You can listen to the right and the left. Most of the time, if you're too deep, you'll have more breath sounds on the right side than the left side, and you're going to pull back to make sure you have equal breath sounds on both sides.
And just as once you visualize the cords, you never want to take your eyes off the cords. Once you get that tube in, you never want to let go of that tube. If you have an assistant, you can ask them to remove the stylet gently while you're continuously watching the tube and the cords to make sure the tube doesn't move, and then inflate the cuff. Some providers prefer to inflate the cuff first and then remove the stylet. Always, always, always remember to keep your hand on that tube anchored pretty low. You can rest your hand against the patient's mouth or lips as you anchor that tube in place. And then after you confirm that the tube is in place, you want to confirm placement. And we've been talking this entire episode about end-tidal CO2, how it is the gold standard. In the hospital, we have colorimetric capnometers, which are pop on and off and change colors when they detect a certain level of CO2. And in the pre-hospital setting, we have the end-tidal waveform, which should give you a capnometric measurement.
I do want to say, though, about like when to remove the stylet. I think when you're in this type of setting where the patient might get jostled or, things are happening, it is probably best to inflate the cuff and then take the stylet out.
Now, what about don't let your ego get in the way? What are your tips about that?
So as someone who's had a lot of very difficult airways, I've had to learn this lesson the hard way, because you want to get that tube, you want to intubate them, and you just get so stuck in your own story of getting this intubation. And then you just have to like make yourself step back for a second and say, okay, what's the best thing for this patient right now? It's to live, right? If all I can do is bag them, then that's okay. And sometimes I just have to bag somebody for a while until I can figure out my next step. So I think that's the main thing. It's like you just think of like intubating as like the end all be all, but you have a lot of other ways to get the patient through this. So whether it's through a supraglottic airway, whether it's through just bagging them until you get to your destination, that's all okay, because your goal is just keep the person alive. And so that's when you're just like, let me take myself and the procedure I wanted to do out of this. And sometimes it's calling for help, like if a supervisor is there and they want to give it a shot, that's also okay. So for example, I'm sure I've had airways where I've called like Danielle into the room, been like, can you come take a look at this? Instead of being like, well, if I couldn't get it, nobody can. So take yourself out of the picture.
And it's true, you just want the best airway for the patient. And so sometimes the best airway in a code is an iGel, or the best airway in a code is a BLS airway, which is like just bagging in an OPA. And then we talked about in our shock podcast, there's a whole move towards resuscitate before you intubate. If they're not in cardiac arrest, but they're in a peri-arrest state, actually intubating them can make them worse. And so you might want to just bag them and resuscitate while you're transferring to the hospital before you intubate them. So as we wrap this up, we've concentrated a lot on intubation and tips on how to go through the intubation procedure. But let's talk about iGel. That's our supraglottic airway of choice here in our local EMS regional system. So let's just go through the procedure on that's in our system.
So the iGel may be used as your advanced airway when somebody is unconscious, so no purposeful movement with an absent gag reflex. If they're apneic or agonal respirations less than 8 per minute, and if they appear to be at least 5 feet tall. This is an adult airway device. The contraindications in our system is for patients under 5 feet tall, a suspected caustic ingestion, suspected narcotic overdose, basically until you try giving naloxone. So don't try to put an airway in before you try naloxone. And if they have a laryngectomy or a tracheal stoma.
With the indications, it talks about an absent gag reflex. And I just want to make the point that to test for that, you can do a couple things. One is the easiest thing, I think, is put an OPA in. If they can tolerate OPA, they don't have a gag. But if they're gagging on the OPA, the iGel is not going to work for you. All right, Sajin, take us through the actual procedure of the iGel placement.
Remember, in any trauma patient, we're going to be keeping inline immobilization of the C-spine. In any advanced airway technique, we're going to be making sure we have suction available. And then we're going to hyperventilate and pre-oxygenate the patient prior to inserting this airway device. So those are constant. The actual insertion of the device, it helps to open the jaw and try to move the tongue out of the way a little bit to the base of the mouth, the inferior jaw. It is a blind insertion, and so we try to use the roof of the mouth as a guide and slowly slide the iGel back into the posterior oropharynx, where it should sit in the supraglottic region. We don't want to interrupt ventilation or, attempt this procedure for more than 20 seconds. If you do need more than 20 seconds, you should try to hyperventilate or bag the patient again prior to trying reinsertion. If you need more than 2 attempts, really it is most important to continue the bagging through either an oral airway, and if really can't ventilate through an oral airway and BVM, then we can try a 3rd time before attempting something more invasive like transtracheal jet insufflation.
I remember that TTJI is used a lot in foreign body obstructions, right? So a perfect example would be John's with the peanut butter and stuck in the airway. If that you couldn't remove that, if you had no tools to remove that, then you would go to TTJI. But it is not used very often in our system, but it is one of the things we have as an adjunct that they can use for airways.
And all of the iGels have a black line, usually around the size number on the backside. And that is the line that should be around the level of the teeth. And that helps you know how far to insert the device. And then secure the iGel with the appropriate straps, I think, that come with the iGel itself. And then you can ventilate the patient and oxygenate the patient as you would through that airway.
Now, some troubleshooting, a lot of people talk about that when you put the iGel in, air kind of escapes around it. So if that happens, first assess, are they still oxygenating? Are you still getting end tidal CO2? If you have a good reading on that, that's okay. If there's a little air leak, that's fine, as long as you're getting good oxygenation and end tidal readings. If you think you've chosen too small, it's hard to estimate size of patients. Sometimes it's hard to estimate height. Remember, this is on height. You can go up to the next size up. So you can pull that and then put another size in. And so you can go ahead and try that and get a better seal. Sometimes I notice that if they are like too gooey, like you have too much fluid inside the oropharynx, like there is not a great seal and you're just never going to get one. And that's okay. It still does its job. Any other tips from you guys on using iGel?
And you can still use suction before and after you place the iGel to try and clear up any secretions in the pharynx, which should hopefully help it sit a little bit better.
And I think securing is key. Using that device that's included with the kit on how to secure that tube is very important. Let's go through some can't miss take-home points from today's talk on the airway.
I think one of the keys is preparation. Have all your adjuncts ready, have end tidal CO2 and oxygen saturation monitoring ready and going on all of your patients who need advanced airways, whether with an iGel or an endotracheal tube or any other advanced airway of your choice.
Remember, the goal is oxygenation and ventilation and airway protection, not necessarily intubation. So if you can bag the patient, if you can give them an oral airway or an adjunct to help them oxygenate and ventilate, that's okay. We don't always have to jump to intubation.
And then when you do go to intubate, you never take your eyes off the prize. You want to watch that tube go through, and you're going to guard that tube with your life. Because as we all know, tubes do get dislodged. You're moving patients much more than we do in the hospital. And so you really want to hang on to that tube. Thanks, everyone.
All right, thank you.
Thank you. If you guys like the American Ambulance EMS podcast and you feel like this has been useful for you, please give us a 5-star review on the iTunes store so that we can move up in the ratings so that other pre-hospital professionals can listen to us as well. And we're also taking any solicitations for ideas or topics that you want covered, and you can email us anytime at podcast@americanambulance.com. Once again, that's podcast@americanambulance.com. Thanks.
Thank you for joining us on the American Ambulance EMS podcast, produced by American Ambulance in Fresno, California. The views of the guests and the hosts of this show are their own and don't necessarily reflect the views of American Ambulance or UCSF Fresno. The theme song for the show is written and performed by Roshan Roach. The beats were created by Young Pear and Brett Schoenwald. And I'm John Mark Bergen, American Ambulance's media producer, saying thanks for joining us Have a great shift and stay safe out there.